Asthma treatment and status asthmaticus. Hello guys, I am Doctor. Today in this video we will be talking about asthma treatment and status asthmaticus. For my previous video on asthma, check the cards above. Initial assessment. Confirm the diagnosis. Ensure the patient's symptoms align with the diagnostic criteria for asthma. Look for a history of variable respiratory symptoms, like wheezing, shortness of breath, chest tightness, and cough. These symptoms often worsen at night, with exercise, laughter, allergens, and cold air. Viral infections can also trigger or worsen these symptoms. Remember, isolated cough in adults is rarely due to asthma. Assess asthma control. Evaluate the patient's symptom control and risk factors using validated tools like the Asthma Control Test, ACT, or the Asthma Control Questionnaire, ACQ. Determine asthma severity. Asthma severity is determined by the level of treatment needed to achieve and maintain control, not by the severity of initial symptoms. This assessment typically happens after several months of treatment. Identify and address comorbidities. Conditions like rhinitis, obesity, and GERD can mimic or worsen asthma. Review medication use. Check for adherence issues, proper inhaler technique, and potential adverse effects. Treatment tracks for adults and adolescents. There are two main treatment tracks for adults and adolescents, differing mainly in their reliever medications. Track 1. Preferred. This approach centers around low-dose inhaled corticosteroid formoterol, ICS formoterol, for both maintenance and symptom relief. Step 1. Infrequent symptoms, as needed low-dose ICS formoterol. Step 2. Symptoms is greater than or equal to twice a month, daily low-dose ICS plus as needed low-dose ICS formoterol. Step 3. More persistent symptoms, low-dose ICS formoterol as maintenance and reliever therapy, MART. Step 4. Uncontrolled on Step 3. Increased to medium-dose ICS formoterol MART or consider add-on therapies. Step 5. Severe asthma, high-dose ICS formoterol plus a third controller medication, e.g., long-acting muscarinic antagonist. Refer to a specialist. Track 2. Alternative. This track utilizes a short-acting beta agonist, SABA, like albuterol, as the reliever medication. Steps 1 to 5. Similar to track 1 but uses as needed SABA instead of as needed ICS formoterol. Important note: using SABA alone for asthma is no longer recommended due to safety concerns. ICS-containing controllers are crucial for reducing severe exacerbations and should be offered to all patients. Treatment for children, 6-11 years old. Initial treatment. Options for initial controller treatment are based on symptom frequency and severity, mirroring the adult-adolescent approach but with age-appropriate adjustments to ICS doses. Treatment for children, 5 years old and younger. Step 1. As needed inhaled short-acting beta agonist, SABA. Step 2. Daily low-dose inhaled corticosteroid, ICS. Step 3. Additional controller treatment, such as leukotriene receptor antagonists, LTRAs, or increased ICS dosage. Specialist referral is recommended at this stage. Management of exacerbations. Self-management. With a written asthma action plan, all patients should receive a written action plan outlining steps to take if symptoms worsen, including increasing reliever and controller medications, starting oral corticosteroids, and seeking medical care. Primary care management. Assessment. Evaluate exacerbation severity using history, physical exam, and lung function tests. Treatment. Provide repetitive inhaled short-acting beta agonists, SABAs, early systemic corticosteroids, and controlled oxygen therapy as needed. Antibiotics. Not routinely recommended unless there is clear evidence of a bacterial infection. Emergency department, hospital management. Assessment. Conduct a detailed assessment of symptoms, vital signs, lung function, and risk factors. Treatment. Administer frequent inhaled SABAs, often via nebulizer, systemic corticosteroids, controlled oxygen therapy, and consider intravenous magnesium sulfate for severe cases. Monitoring. Closely monitor the patient's response to treatment and adjust management as needed. Ongoing management. Regular review. Schedule follow-up appointments to reassess asthma control, adjust medications, address adherence and inhaler technique, and modify the treatment plan as necessary. Step-down therapy. Once asthma is well controlled for months, consider gradually stepping down treatment to find the lowest effective dose. Patient education. Emphasize self-management strategies, trigger avoidance, proper inhaler technique, medication adherence, and the importance of following their written asthma action plan. Important considerations. Shared decision-making. Engage patients in their care by discussing treatment options, potential side effects, and their preferences. Individualized care. Treatment plans should be tailored to each patient's specific needs, considering their age, symptom patterns, risk factors, comorbidities, and response to therapy. Accessibility of care. Recognize that barriers to accessing care and medications can impact asthma control. Treatment of status asthmaticus. 1. Recognize the emergency. Inability to speak. Patients with status asthmaticus often struggle to speak in complete sentences due to severe breathlessness. Respiratory distress. Observe for rapid respiratory rate, 25 breaths per minute or higher, indicating the body's attempt to compensate for poor oxygen intake. Elevated heart rate, tachycardia, and increased heart rate, 110 beats per minute or more, is another sign of the body trying to compensate for reduced oxygen levels. Abnormal peak expiratory flow rate, PEFR. A PEFR significantly below the patient's personal best or predicted value suggests a severe obstruction. Silent chest. Be particularly alarmed if you notice a silent chest, an absence of wheezing, as this could indicate extremely poor air movement and impending respiratory failure. 2. Immediate actions. While arranging urgent transfer to hospital, supplemental oxygen. Administer high-flow oxygen to address the low blood oxygen levels, hypoxia, characteristic of severe asthma exacerbations. Aim to maintain oxygen saturation between 94 to 98%. Nebulized bronchodilators. Provide nebulized bronchodilators to rapidly open up the constricted airways. Salbutamol, albuterol, a short-acting beta-2 agonist, SABA, that relaxes airway smooth muscles. A typical dose is 5 mg. Ipratropium bromide, an anticholinergic drug that further enhances bronchodilation, often used in combination with salbutamol. A standard dose is 0.5 mg every 6 hours. Systemic corticosteroids. Administer systemic corticosteroids to combat the underlying airway inflammation. Intravenous hydrocortisone, 100 mg is a common initial dose. Oral prednisone, 40-50 mg can be considered as an alternative if intravenous access is not readily available. 3. Continuous monitoring and further management. Monitor vital signs. Regularly assess vital signs, including heart rate, respiratory rate, oxygen saturation, and blood pressure, for any signs of deterioration. Assess PEFR. Continue to monitor PEFR to evaluate the response to treatment. Repeat nebulizers. If the patient's PEFR remains below 75% or their condition doesn't improve after the initial nebulizer treatments, repeat the salbutamol and ipratropium bromide nebulizers every 20 to 30 minutes. ECG monitoring. Continuous ECG monitoring is crucial to detect any potentially life-threatening heart rhythm abnormalities, arrhythmias, that can occur in severe asthma exacerbations. Consider intravenous magnesium sulfate for patients with severe or life-threatening features who are not responding adequately to initial therapies. A single dose of intravenous magnesium sulfate, 1.2 to 2 grams over 20 minutes, can be considered. Magnesium sulfate acts as a bronchodilator and can be highly effective in these situations. 4. Disposition. Home discharge. If the patient's PEFR improves to over 75% and they maintain stability, they can be discharged home with a prescription for inhaled corticosteroids and oral prednisone. It's essential to provide clear instructions on medication use, follow-up appointments, and their personalized asthma action plan. ICU admission. If the patient's condition deteriorates despite aggressive treatment, they will require admission to the intensive care unit, ICU, for closer monitoring and advanced life support, which may include mechanical ventilation. Important considerations. Early recognition is key. Prompt recognition and immediate action are paramount in managing status asthmaticus. Delays in treatment can have dire consequences. Written asthma action plan. Ensure the patient has a written asthma action plan to guide self-management and help them recognize early signs of worsening asthma. Inhaler technique and adherence. Reinforce proper inhaler technique and the importance of medication adherence to prevent future exacerbations. Address triggers. Identify and address the individual's asthma triggers to minimize the risk of future attacks. Thank you for watching the video. You can check out other similar medical lecture videos in my channel.